Thank you so much, Angie. Thank you, everyone, for joining today. It's wonderful to be here with you. As has been mentioned today, we're talking all about serum, saliva, or urine, and really helping you to be able to choose the right test for your patient. So many of you may feel super confused about all the different options that are out there and testing mediums, or you may have, your favorites already chosen, whatever, is working for you in clinical practice. And I just want to say that, that is great. All of these mediums have their benefits and their challenges. So pros and cons. So we'll just go through today and make sure you feel really comfortable knowing the pros and cons of each method so that you can just simply choose the one that works for you and your patients in your clinical practice. So hopefully that helps. I think there's, somewhat of a controversy about this out there. Which one do we choose? Which one's the best? Which one's the most correct? Serum, saliva, and urine. In my opinion, it's kind of like comparing apples to oranges to pears, and arguing over the differences there. Is there one that's better than the other? There are arguably pros and cons, like I said before, but they're all wonderful for their own respect. I do choose them for different reasons, but one of the main takeaways that I'd like for you to walk away with today is that there's no wrong way to test hormones, but again, there are pros and cons to each of these mediums that we'll just want to be mindful of as we go through. Okay, so a good teaching point here is the story of Lance Armstrong. If you've ever wondered how the heck he got away with winning the Tour de France 7 times while using performance enhancing drugs and never admitting to that or never being caught, you'll have that answer by the end of today. The bottom line is that Lance and his team of docs knew about the nuances of tracking these sex hormones or steroid hormones in various testing mediums, and they were basically able to exploit the weaknesses of the doping control system, which is still on a big scale what is happening, throughout the medical field. So there's a bit of a misunderstanding of some of these nuances. So by the end of this lecture, you're going to be the practitioner that would have caught Lance right away, and he wouldn't have gone away with this for 7 years. So as we get started, I want to remind us all of the steroid hormone cascade. These steroid hormones are made, remember, from a cholesterol backbone. That's the very starting material. So like cholesterol, these steroid hormones are not soluble in water. They're hydrophobic and lipophilic. And this is just a really important concept because when we're talking about serum and urine, those are water-based substances. And because these hormones are hydrophobic, when they're in these watery environments, they have to be bound to a carrier protein, or they have to be what is called conjugated. So this simple concept is really an essential one when we're talking about comparing the different mediums. And if you know this, you're well on your way to really understanding everything from there on out. Okay, this is also why talking about steroid hormones or sex hormones is very different. It's a different conversation than talking about hormones like thyroid hormone or luteinizing hormone, some of these more protein-based hormones. So we've had this testing evolution that's happened over time, and I just want to give you a big picture here so you kind of understand where all these mediums came from and when those arose. So urine hormone testing was actually the very first type of testing that was picked up and used clinically. It was in the 1940s and 50s. And at this time, they were using a chemical method. It was fractionated with a solvent to make it soluble for testing. So, we've made advances since then, but that's how it started. In the 1960s, then we came out with gas chromatography mass spectrometry, and that uses derivatization, and it's less sensitive than what we have now, which is called LCMS, or liquid chromatography mass spectrometry. So you can see, how these started and how they've been improved over time. The 1970s is where we first see radioimmunoassay for estradiol in serum. And this was started with estradiol, and then it was applied to testosterone and progesterone. The early 2000s, this is really where LCMS came up, and you'll see that as kind of the gold standard today. This is liquid chromatography mass spectrometry, and this is the way that a lot of specialty labs and universities use this type of testing because it is the most accurate. And then interestingly, serum testing, I might be bouncing around here. Serum testing came in the mid 1970s. And then we came out with something called direct immunoassay. This is to this day, 99% of hormone testing is done this way. The challenge with this is that we're always having to deal with these binding globulins and accounting for that and trying to separate out the bound hormone from the free hormone. Okay. And then these specialty labs, as I mentioned, did come out with direct LCMS. It's very rarely used in standard serum testing today because it is more expensive. And when you're talking about running a massive amount, say in hospitals, things like that, in clinical practice, a lot of times you just don't have, the finances to do that. Salivary testing started in the 1980s, but really picked up in the mid 2000s. And I do want to mention here in 2010, Johns Hopkins University created an Institute for Interdisciplinary Salivary Bioscience Research. And I want to mention that. And then after Johns Hopkins, University of California followed suit too, and they also have their own, and that was created in 2016. Just to point out, because I think sometimes people that I speak to really feel like salivary testing isn't as legitimate as serum testing. And I do want to just point that out, that there is a lot of legitimacy to all of these testing methods. Again, we're just kind of looking at it's a different way to look at the hormones in each medium. And if we try to make them look the same, we're going to really be struggling there. Okay, so let's first start with serum, then we'll look at urine and then saliva as far as these pros and cons. We'll just break it down one at a time. The advantages of serum is that it's really the best place to test for polar molecules, things like thyroid hormone, prolactin, LH, FSH. And I mentioned that these steroid hormones like estradiol they're non-polar and hydrophobic. That's another term for that. The polar molecules are water soluble, they're hydrophilic, and so they're best tested in serum. Their polarity allows them to form hydrogen bonds with the water molecules so that they're soluble. Okay, so this is the most well-accepted mainstream marker. It's considered the gold standard, and this is usually due to, when we're talking about big picture here, time, wide acceptance, and familiarity, and cost. Okay, it's the most widely used medium in research settings. It's quite convenient because you can draw and order a lot of things all at once. And it is the best place, like I said, to test for these polar molecules. It provides a snapshot of the total levels at the time of draw. So we know that the human body is so dynamic and things are always moving and fluctuating pulsating every few seconds, probably even minutes. This happens throughout the day in the circadian rhythm and throughout seasons. So remember, anytime we're doing this, we're getting just that snapshot. Disadvantages, I don't know anyone that loves getting their blood drawn with needles. We're limited to venipuncture access, so we can't really be looking at arterial blood very easily. You could argue it's a little inconvenient to the patient depending on the time of day needed to collect the sample. They may have to sit and wait at a laboratory setting, get to the draw site, fasting might be required. And all of these blood tests are giving a single point in time measurement, which may not be reflective if we are interested in that pulsatile nature of human physiology. So there can be some nuance there that we need to be mindful of. The tests for serum measure the total amount of hormone present, which is not as reliable a reflection of the hormone that's actually available to the tissues, the bioavailable or unbound portion. Okay, and this is one of its main limitations. The free levels to actually directly measure these in serum is very expensive, very technically difficult, and I'll talk about that. And these binding proteins, which happen when this fatty molecule is moving through a liquid medium, can obscure the hormones. So if you're looking mostly at bound or the total, especially if somebody is taking, say, oral estrogen, that's going to increase sex hormone binding globulin, and those binding proteins can affect estrogen, testosterone, cortisol, but can bind any of the hormones. Okay. And it's not the most effective way to accurately monitor topical hormone replacement dosing, especially progesterone. And I'll talk more about this as we go. Okay. What did I skip over? Okay. So some disadvantages, we talked about those binding proteins that can really obscure the level that you're trying clinically to obtain, so that you know what is getting to this patient's tissue. And then if we have if we would like a diurnal test, that would require a patient to visit the lab 4 times over the course of the day. This is specific for cortisol. It's a great test for diagnosing Addison's or Cushing's, but it's typically not sensitive enough to catch those functional changes. And then if we have white coat hypertension or a patient with a difficult blood draw, that can increase cortisol, and cortisol, being secreted in response to stress, ACTH will secrete first and then cortisol will follow. That can change those levels, obviously. One of the biggest challenges in testing steroid hormones in serum is that they're largely, again, bound to those protein carriers. So there are methods to separate free from bound, and we do this in vitro. Something called equilibrium dialysis is considered the gold standard. And I'm going to talk about this a little bit more as we go, but I do want to mention here that it is considered the gold standard, not necessarily because there's experimental evidence to support it being the gold standard, but because it's adhering closely to what's called the law of mass action. And that's on one of the next slides. Now, equilibrium dialysis, again, gold standard, if we're able to, and this is usually in a research setting, directly separate free from bound in vitro. Now, there's other ways to do that too, but all of these ways are technically difficult to do. And so it just really increases the cost of the testing. It's not usually offered at all in standard clinical blood testing. And so then what we have to do is use an indirect or calculation method. And this is always what's done. If you send your patient's blood to, the standard places, this is what's going to be done, is that calculation method. Okay. I think this is such a brilliant statement that Matsumoto said in 2004, that this type of work, meaning sex hormone laboratory testing, is relatively, and I would argue, very not sexy, okay, despite the hormone being measured. And it would be viewed as pedestrian by many funding agencies. It's quite mathematical, and many clinicians find this type of work very boring. This is an entirely different field than clinical practice. This, studying of these sex hormones and, how are they moving? And, it's kind of like organic chemistry. Some of us loved that, but a lot of us, weren't such huge fans. So looking at these calculations can be daunting. So the papers that are published about this, a lot of times just kind of cause eyes to glaze over and we move on. But the problem is that these descriptions, both the measurement and the statistical analysis, are really important for clinical and research audiences. If we can get to the point where we can, get through all that density. So I'm hoping today that I'm able to, as a clinician myself and as someone who part-time works in a laboratory setting, kind of help you meld these two worlds, because otherwise you just wouldn't have exposure to this as a clinician. This is not something that you learn in medical school, and it's quite unsexy to study. So these are the calculation methods for free hormone levels. There's many different calculation methods. The one that's most commonly used is called the Vermeulen equation. This is mostly well accepted, the most well accepted, I should say. And then you'll see here, the free androgen index, which is given here, very simple calculation, the total testosterone divided by sex hormone binding globulin multiplied by a factor. And so sometimes if you're asking for that free level of testosterone, it's simply this calculation that's given. So we have to question, is this correct? I think not a lot of time probably goes into, and it's probably really uncomfortable as a clinician to wonder, like, hey, are these calculations I'm getting actually correct? And can I use this clinically? This is the Vermeulen equation. So you can see it there at the top. It looks quite cumbersome and detailed, but basically what they're doing here is taking a calculation using free estradiol, albumin, sex hormone binding globulin, total estradiol, and then there's something called the association constant, which is the how much affinity does the hormone have to bind to albumin or SHBG. So that binding affinity changes. And so we have all these different factors. All of these things can change throughout. And so we have to realize this calculation came from the law of mass action. This was originally, the work was done in the 1800s, and it was focusing on chemical kinetics in simplified systems with reactants in relatively dilute, pH buffered, and aqueous solutions. So that all sounds wonderful and textbook style to study this and to study, what the law of mass action is, and can we, utilize this in a clinical setting. But I think you can all say at this point, my patients are quite complicated biological systems in their human bodies. They are involving, these bound particles. Are they pH buffered? Are they dilute? Is this a simple, laboratory setting system? So when we bring all of those dynamics in, it makes this equation quite stiff. Like, it's not able to account for all of these different aspects, temperature changes, and various biochemical changes that our patients are going through. And so this potentially can explain some of the inconsistencies between direct measurements, meaning those research setting, expensive equilibrium dialysis readings, versus the calculation of free estradiol that's been shown in many studies. It's not just one study, but there are some challenges and discrepancies there, and we have to say, like, what the heck is going on? So remember all of those different aspects in the Vermeulen equation, one of which is sex hormone binding globulin albumin. So there are issues here where this level can definitely change. We see it changing over time. With albumin decreases with age. We see sex hormone binding globulin is actually sensitive to denaturation. And we have sex hormone binding globulin changing with obesity, androgens, prolactins, puberty, progestins, right? None of the calculation can't account for any of this. And so this is where I think the calculation, unfortunately, just becomes such a stiff textbook, perfect analysis that's not able to dynamically account for what our patients' true hormone levels are, which is really the question we want to know, right? Rosner in 2015 reported that there was a greater than threefold difference between the highest and the lowest association constants for estradiol binding to sex hormone binding globulin, and then a twofold difference between the highest and lowest association constant for estradiol binding to albumin. Okay, so we see that there's an issue there. Sex hormone binding globulin and albumin are the only binding agents in that Vermeulen calculation, right? But we have several studies that are actually telling us that there's other hormone carriers to consider, not just those two binding globulins, namely red blood cell membranes and lymphatics. There's probably others. And so you can start to see where we start questioning, hey, maybe the sky isn't blue anymore. Serum testing may not be the end all be all. And we might want to go back and look at this stemming from the 1800s and really start to reanalyze, what we've been doing in the medical field. So even a negligible variation in that binding protein capacity, say 1% difference, can produce dramatic changes in that very end of the free steroid hormone report. There's been a number of publications that find disagreement between the measured and calculated values of free estradiol and free testosterone in serum. So again, this is just, an issue that we're facing in medicine. And if these methods for free hormone calculations are potentially flawed, this raises the question, about maybe what we're doing, even in clinical practice. Okay, so the methods shown to be inconsistent with serum values, I would like to point out, because of everything we just talked about, are not necessarily flawed. And the methods consistent with serum values may not be inherently correct, right? So if our baseline has changed, if the gold standard is raised into question, everything that we compare to that and then throw away because it doesn't match that, or maybe we accept it because it matches it, we have to question that. Okay. So despite all these issues, the calculation is still the most prevalent way that free estrogen is reported. And with consistent calculation factors, the results between the serum measurements can be comparable, as Rosner said, thus giving the false impression of accuracy by the majority. So I know when I first read this, I felt uncomfortable. I was like, oh, great. Okay, the sky isn't blue. Now what do I do? Because, we've been relying on this for so many years as clinicians. But while measuring sex hormones in serum is economic, it's efficient, it's simple, there is some potential for variation and inaccuracy there. And I just want to bring this up because I don't think it's spoken about too much. So we do have this ongoing debate. And the standardization is problematic. The discrepancies around sex hormone binding globulin is probably the biggest unsettled issue in laboratory science. So please know that this is out there and that, it hasn't been settled yet, but, these are the challenges we're facing. So we've got that issue with sex hormone binding globulin. I'm just kind of analyzing and summarizing everything we talked about here. The law of mass action, right? It's great in a textbook scientific setting that's really highly controlled, but likely doesn't apply a whole lot or doesn't apply accurately to our patients. That Vermeulen calculation, it's widely used for free testosterone, is considered the most accurate. And then it was applied to other sex hormones as well, which, begs a bit of question there. These calculations can change from sex hormone binding levels changing and may not be accurately reflected in that very static calculation. Okay, so at the end of the day, I think you still have to do what works in your clinical practice. And for a lot of you, if you're in a big clinical practice and you are being mindful of finances and time and efficiency, serum is still going to be your best way. Okay. And so I think, just being cautious to use the steroid hormone monitoring, if you're doing that in serum at the same laboratory every time, that can account and help, to control for some of that variation. But again, you, like myself, you're probably a little uncomfortable with that still. And that's just where we're going to have to leave it for now, because that's what we're faced with. We're going to use this table as a starting point and build on it as we continue today. So we're going to first start with serum and understanding its relationship to supplementation, which I think is a lot of times the big clinical question that we want to know is, am I giving my patient the correct hormone, the correct amount of hormone? So if we're looking in serum, can we use that to determine endogenous steroid production? Yes, you certainly can. Can you use it to look at the delivered amount of oral supplementation? Yes, with the caveat that this oral delivery creates conjugated metabolites when it's going through first pass through the liver. And the immunoassay in serum may not be reflective of that. Can it be used to track topical? I will argue no, and I know a lot of people are using it this way and seeing changes. So as we talk, I'll give more detail about that. Vaginal would be very similar to topical. I would argue it's not the best way to use that testing, and you're not going to accurately be analyzing the dose that's given. You're usually overdosing the patient in order to get that serum level to change with a topical application. And that's simply because of the way that the transdermals move through the body and are absorbed. They're not going through venous circulation unless you're getting really high levels and it's kind of slopping over from capillary sites and tissues. Sublingual, we'll give this a maybe. It's very similar to topical or vaginal, meaning it's a transdermal. It's going directly to capillaries through the skin. Some amount of that sublingual is going to be swallowed. So therefore, you're delivering the hormone orally and you're subjecting that to first pass metabolism. So you may see some of that from that oral delivery, but if 99% of it is going sublingually, like truly sublingually, you're not going to be seeing that in the serum unless you massively dose and then it's slopping over again. Pellets or intramuscular injections. Yes, you can see that it's delivered and spread throughout the body very similarly to endogenous production. So in the same way, you'll be able to see, relatively well. Now, you still have the issue of the calculation factor, getting that and getting the free level that you're really interested in probably. So there's still that. Clinical pearls, I would say, if you need to rely on serum testing, just, be mindful. And this is for any type of medium that you're really relying on, listening to the patient and their experience. And, I think it can just be so easy to follow the laboratory numbers, and the patient symptoms can become very complicated. And it's hard sometimes to pull those out and to decide, is this a thyroid thing? Is this just, their poor diet? Is this actually hormone symptom based on, the dose that I'm giving them or the dose that's being changed? And so, being aware of that, this is somewhat of an art form. I realize it's not black and white, but remembering to listen to the patient too and their experience. Anytime you change hormone replacement, bioidentical or otherwise, if you're changing that dose, there is a recalibration that happens in the body, and there can be some discomfort and symptoms from that. It doesn't necessarily mean you're headed in the wrong direction. So you have to be mindful to help patients delineate and discern what is happening. Tachyphylaxis is the name of a progressive decrease in response to a given dose after repetitive administration. Usually when the dose is quite high, you get this kind of downregulation of the receptor sites and somewhat of an ignoring of the hormone that is there. So a lot of times you'll see this when patients are given really high amounts of hormone, especially say males and in testosterone injections. They get some benefit for a while, but then they don't. Then it feels like they don't have any testosterone anymore. And it's because there's so much testosterone that the receptor sites downregulate, and there's basically the body kind of, resisting what is there. But at the end of the day, you have to use what works for you and your patient. So again, whichever medium works for you, go for it. There's always pros and cons to that. So just be aware of those and you'll do great, and your patients will be well off. There is this idea of exogenous hormone risk. I would argue it looks more obvious to me that endogenous excess. So if someone's making their own hormone and it's in too high of amounts, that's more risky. Usually we're talking about like that overactive aromatase enzyme than giving exogenous hormone in larger amounts. I don't think that's been proven. That's my sense. And so maybe we could say, hey, there's not, as much risk potentially, but I think really what we're after is that tachyphylaxis that happens, that downregulation and ignoring the hormone so that the patient is suffering as if they were not getting any hormone replacement when they needed it. That's really the major risk that we're trying to avoid. Okay, on to urine. Advantages here, no needles, it's stable. You can collect at home any time of the day or month, any place. Great for measuring cortisol and luteal surge, the progesterone level at the right time of the cycle. And then urinary hormone testing is the only way to see how the body is metabolizing hormones. So it really stands out for that way. That purpose is looking at those metabolites. You've got a few different options here. There's a liquid urine. There's also dried urine out on the market. With liquid urine, you can do a 24-hour collection, an AM collection, or a 4-point collection. With dried urine, that's usually a 4-point collection. Benefits to dried urine. You do have analytical sensitivity, meaning you're concentrating that urine and able to see some of those small metabolites. You do have a little bit of enhanced stability. So in the dried form, the cellular components don't continue to metabolize or form compounds, other compounds, that could be affecting the main hormone that you're trying to measure. The drawbacks here, the patient does have to restrict water consumption, which is actually quite extensive, less than 20 ounces in a day. So I know my patients usually drink so much more than that, so that can be a little difficult. The sample matrix, the cards were designed for whole blood, not urine. And maybe this doesn't raise any red flags at this point, but I'm going to show you a slide kind of towards the end of the presentation where we really question we have to be really careful about that, using the sample matrix that was designed for that medium. There is some higher variability, both the sampling and the reconstitution. So once the dried urine arrives at the lab, it has to be reconstituted back into a liquid form. And really the issue with that is that all urine components are reported in terms of excretion per creatinine level. The true creatinine level is not known here, but it has to be estimated based on a standard extraction of the dried sample back into liquid form. And so that variability of creatinine is really important because that's used to measure everything else from that sample. So we have a higher degree of imprecision and a lack of reproducibility if we're comparing this to a liquid urine sample. Okay, so I would always prefer to test in liquid if I have the chance. And then with the dried urine, there's some additional sample handling steps for patients, in the bathroom when they're collecting this. I don't know. Sometimes my patients do the craziest things. You have cleaning supplies and aerosols and things, and I don't know what they're all doing in their bathroom. And you have more risk for, contaminating that or making that more complicated, picking up some aerosolized particles. Benefits to liquid urine testing, we have ease of collection, we have method standardization. This has been used for a long, long time, and better reproducibility, okay? So I would always choose this if I had the choice. Drawbacks to liquid, there is some idea that these components in a dilute situation where there's way too much water consumed prior to collection, that some of these components could be undetectable. Remember, these hormones are already quite small molecules. Then we're talking about metabolites, boom, 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 like on down the line. These get teeny, 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 tiny molecules that we're trying to measure, okay? So we do have that risk, but I would say it is quite rare. And then we do have a need for stabilization. So to minimize the effects of bacterial growth, the samples have to be acidified and chilled for transportation to the lab. As you can see, if you have anything else in the urine, if that's not a sterile environment. And so you do have to be mindful of that. And laboratories will usually be aware of that and, provide stabilization and advise that patients freeze the samples before shipping. So disadvantages to urine, it's difficult to measure the frank parent or unconjugated hormone levels. And you can't use urine testing, I would argue, to accurately assess topical or oral medications. So it's not reflective of tissue uptake, and it's not going to be reflective of topical hormone usage. And that's because of the way the hormone is being absorbed. Okay. You do get high metabolite levels with oral medications, just simply because of the way that it's moving through the body. So just be mindful of that. Urine can be used for measuring diurnal cortisol levels, but the urinary free cortisol output reflects a pooled average of the time since the previous void of urine, usually in hours. Saliva is providing more of an instantaneous assessment of the time at the time the saliva was collected in minutes, whereas urine, you have a little bit of a delay there. Okay, so estrogen is metabolized through phase 1 and phase 2 detox, primarily in the liver. In phase 1 detox, it's hydroxylated with the CYP system. So I think this is really the reason I want to point this out, is because this is where the urine testing shines, is that you're able to see these tiny molecules breaking down and the patterns at which they're moving out of the body. And then we have some studies showing us that certain metabolites fare better for health, and some are more risky. And so the direction at which these hormones are being broken down can give us information about this person's risk factors. And then we have studies like this on diindolylmethane that tell us, hey, if you have these metabolites that are moving towards the 4-hydroxy side of estrogen breakdown, and you want those to go more towards the 2, which is usually what you want, things like diindolylmethane will help you do that for the patient. And so this is why this type of testing is so helpful, is because you can see these types of risks, the metabolites, the direction that they're moving in, and then utilize things like that to change the way that the person is metabolizing. This also, you can relate to things like prostate cancer. So it's not just for females, but we do see more 2OH, the safer pathway. We see less prostate cancer risk, and some of the other patterns lead to more risk. Okay, so then we also have phase 2 detoxification, or this is accomplished with a COMT enzyme or methylation. So we can see if these hormones are being methylated. Are they moving from phase 1 to phase 2? And this has a lot to do with health. This is a very, very important part. And so helpful to see that. If the estrogens aren't moving from phase 1 to phase 2, we get oxidation, which is damaging. And this is something, we have to be monitoring. And so if we don't have phase 2, we have higher health risk. So this is also where you're able to see this. So a lot of benefits to urinary metabolite testing through estrogen, androgens, cortisol, progesterone, even looking at carcinogenic potential. But what we want to keep in mind when using urinary metabolite testing is that whatever we're measuring as far as the parent hormone level in the urine may not be a direct reflection of the tissue levels. Okay, so if we're assuming that the hormone, it's high in the urine or low in the urine, therefore it's high or low in the body, we're making quite a bit of assumption. And I think this is where the nuance really, shows itself. The urinary metabolite hormone levels also may not be a direct representation of circulating active tissue hormone levels. So urine testing really has a great potential to overestimate or make oral hormone supplementation look like, it's way too high. All of these metabolites are elevated and the parent hormone is elevated. And that's simply what it's simply showing you is this is how the hormone is moving through the body. It's going through first pass in the liver. We get a lot of movement there and excretion out in the urine every 24 hours. It's simply reflecting that. So to say, I need to reduce the dose, you can see how urine testing is not the best way to utilize. It's not the best way to utilize urine testing to be adjusting dosages like that. The very opposite end, the urine testing is going to underestimate topically applied hormones. You're really not going to see a whole lot of that. You may see some movement, but it's not going to be representative of the dose that you're using. Okay, so changing the dose is not what I would advise based on getting those urine levels. So we'll add to this table here. We have urine. You can look at endogenous steroid production. You can look at oral. Remember, it's going to look quite high, but you can see it there. I would argue you shouldn't be picking up a whole lot of topical in the urine unless, again, like serum, you're dosing quite high. You can see some uptick in the metabolites, but again, it doesn't mean, oh, I need to change the dose based on this. It's just simply reflective of the use of that. Vaginal, very similar to topical. Sublingual, again, it's a maybe. These really track serum levels quite well. You can see like it's the same answers for each category. And then with pellets or intramuscular, yes, you can see that because it moves through the body much like organ production. So at Doctor's Data, we currently have a 4-point liquid urinary hormone metabolite profile. It's called the HUMAP, stands for Hormone and Urine Metabolites Assessment Profile. And we spent years in research and development trying to find the best, the most accurate way to test these samples and to give accurate hormones and metabolites in the urine. So we determined that the liquid urine was giving us the most reliable and reproducible numbers. And we do use LCMS, tandem LCMS to analyze the urine, okay? So that is a representation or just a picture of what the test looks like. So it's looking at an overview of the steroid hormones, their metabolites, and the efficiency of the enzymes can be derived from looking at the way that those hormones are being metabolized. It's a non-invasive test, requires 4 or 5 liquid urine collections. And that is what it looks like. And then this is the second page of the test. It's just giving a big overview of all of the hormones and their metabolites. And what we've done to try to help just clinically, which I think a lot of people are finding a lot of value out of, is just to numerically give a digit for each one of the enzymes that we might want to target. So if you see a pattern that you'd like to change or you'd like to optimize for the patient, we've put this together where you can simply take that numerical value that you found representing the enzyme and go to a treatment considerations document here and say, for say number 9 for 5-alpha reductase, if you want to dampen that down, which is usually what you want to do, you would look at the minus symbol and choose any of the treatments within that. So I think clinicians find this super helpful. It's kind of like a little puzzle to put together once you get that testing done, and you can utilize the hormone metabolites that way and really target the enzymes to improve health and the metabolism of those hormones. Okay. Next, we're going to look at saliva. So some advantages here. We're always looking at the active or the bioavailable unbound portion of the sex steroid hormone. So we can use this for clinical assessment or to monitor any type of hormone replacement, bioidentical or otherwise. It's simple and convenient to collect, and it's non-invasive. So when we talk about free versus bound hormones, this is where this becomes really important. So these endogenously produced hormones are secreted from the ovaries, the testes, or the adrenals. And when they are secreted, they're wrapped in a protein envelope, sex hormone binding globulin, cortisol binding globulin, et cetera, so that they can be transported around in that aqueous system, okay? But these bound hormones are not biologically active. And really what we care about as clinicians usually is that 1 to 10% that's unbound and what's actually going to the tissue, not what's on backup, just kind of waiting in the serum. So saliva is only able to show you those biologically active hormones. The size of the salivary duct is small enough to where if anything got through there, it cannot physically be bound. And this is very likely representative of what's happening at the very same thing happening at all the tissue sites, the brain, the bone, the cardiovascular system. Okay, so it's optimal for collection at any time of the day or month. And it's really the most effective method to accurately measure these transdermal therapies. You can measure any therapy, but really it stands out because of that the way the transdermals are absorbed is so unique that we start overdosing if we're using anything other than saliva to measure that. So you can see what is bioavailable, both endogenous and therapeutically delivered. And the saliva is looking at really the capillary flow around the saliva glands. These nonpolar molecules are able to freely diffuse across the capillary membrane and into the salivary tissues. So that allows us to look at the bioavailable fraction of the hormones, and then it's assumed that that is very similar, again, to what's happening at the tissue site. So we have these endogenous hormones that are attached to protein carriers. When the hormones are applied transdermally, they're not attaching to those protein carriers like when they're produced naturally by the body. They're attaching to red blood cells. But either way, they're moving through these small capillaries. They're typically cleaved off. They're able to move directly into the tissues. So again, when, say, progesterone, for example, is absorbed through the skin, it's not coated in that protein carrier. It's carried by the blood's fatty components, like the red blood cell membrane. Okay, so we see that transdermal progesterone is absorbed very quickly, shows up in salivary testing within minutes to hours, indicating that it is very well absorbed. It's available to the tissues in biologically active form. Only when the progesterone level exceeds the carrying capacity of that fatty material in the blood, the red blood cell membranes, it's going to slop over and then show up in the serum. So typically, when serum levels of transdermal progesterone are increasing, it's usually a sign of overdosing. Okay, this is an example here. Topically applied progesterone of 64 milligrams. There was a single dose given to some women looking at salivary and serum progesterone and urinary metabolites. The saliva change was remarkable, showing levels changing within 30 minutes and not showing in the serum or the urine. Okay. And just as a reminder, it's really progesterone is the one that I point out the most because it's going to be the most, it's going to look different in saliva versus serum more so than any other hormone because it is so much further up on that steroid hormone cascade. So it's so nonpolar. It does not like to mix with water. There's less of a difference when you're talking about estradiol. See how far that is down the pathway. So it has less strength in its nonpolarity. It's still nonpolar, but if you're trying to compare serum and saliva, there's going to be a little less difference, a little less disagreement between those two. There's going to be a lot of disagreement between the progesterone. But I would argue anytime, again, you're using serum to track transdermals, you're going to be overdosing. And then you have tachyphylaxis. Okay. So salivary testing is really a great medium for cortisol testing because you can get this diurnal pattern multiple times through the day. You can get the cortisol awakening response, which is looking at that cortisol within 5 minutes of waking. You can't do that in a blood draw, get to the lab and all of that. And then again at the 30 and 60-minute mark. So you're avoiding all of these logistical issues and able to just capture right then and there that pulsatile nature. Okay, and this is an example of that pulsatile nature. This is looking at sex steroid hormones fluctuating every 10 minutes in picograms per milliliter. So there's just a lot of pulsatile nature to human physiology, and we have to do our best to be able to account for that. Saliva limitations, we are at this point in time for your standard tests, we're restricted to steroid hormones, not to these more protein-based hormones. So there is less of less number of assays available that you can even choose from. This is, I think, in the future going to change. There are many more tests that are coming out and being developed. But at this point, this is still fairly standard that it's just looking at these steroid hormones. It is technically quite challenging, so the laboratory has to be knowledgeable and knowing what they're doing. If the saliva specimen comes into contact with any particle of a topical or sublingual hormone on the lips or the hands, that can contaminate the sample and make the level look super, super high. And laboratory quality control matters here. We don't have as large of a degree of the utilization of saliva testing compared to serum worldwide. And so we have to make sure, that there are standardizations happening. So this is an example. This was that study I wanted to point out where they were looking at passive drool. So you see the dotted line there in blue, and they were measuring testosterone levels. Then they compared that to a salivary swab and found really good data showing that it was very similar in measurement, and that's the blue line again. Then they used a cotton swab to test testosterone, and look how different the values are. So this is why they actually found that the presence of the plant sterols in the cotton was cross-reacting with the steroid immunoassays. So this is like that unsexy laboratory science that someone's got to do and analyze. And so if you see a laboratory using something that wasn't developed for that very specific and tested for that, medium or, whatever, saliva, urine, whatever that was being used, and it's not matching, we have to unfortunately pause and say, oh no, we need to look into this further, because something like this could happen where you're getting some really odd things that maybe at first glance wouldn't be obvious. Now, there are 7 attributes of a high quality salivary bioscience laboratory. And, not all laboratories that do salivary testing have to follow these. Some will, and some will do it even without being kind of signed up for these proficiency type of institutions that follow them. But these are the 7 that you want to know as a clinician that this laboratory is following. Okay. And so it would just help to be, you would have less guesswork as a clinician, and you'd be able to, rely that this laboratory setting is doing their due diligence to make sure they're following, all of these things. I do want to mention here just a few other things, because saliva doesn't get as much attention as serum, that it is, the estradiol is FDA cleared for IVF. It has standardization within the industry. There is a center of excellence in salivary testing. As I was mentioning, they oversee that, make sure the 7 attributes are being followed, and providing third-party quality assurance to salivary labs all around the world so that there's standardization here. Saliva is not a research use only. It is the best available assay for assessment in humans, okay? It's not a lab-developed assay. Anytime you see a laboratory that's the only lab using that assay out there, you do have to give pause and say, okay, what's going on here? So remember that saliva is not a lab-developed assay. This is standardization throughout the world. And there are validations across the world. Collection and storage, though, really matter. Some companies pool estradiol levels, so you have 4 samples in one day, and then they pool those, and some do not. So if you're studying laboratory to laboratory and you're getting different values, that can account for some of that. And then remember that the variance between the calculated free levels in serum, and if you're comparing that to saliva and they're not the same, that doesn't mean saliva is inaccurate. Accurately tracking hormone replacement dosages. We've talked about this a little bit, but I want to dive into it a bit further here. This is showing why after 22 days of a topical application of progesterone, there was a new baseline that was reached in saliva. So it's showing that it's a really nice and solid tool for monitoring. So not after a single application, but after about 22 days, you can see a new steady baseline. So with that baseline, then we can compare, okay, is serum rising after that topical application? We can see an immediate increase in application in saliva, but not an increase in serum, remember? And that would kind of match what I was saying earlier, that you're not going to see serum levels rise too much unless you're giving really higher and higher levels. And this is typically what's been done, even in kind of standard pharmaceutical or hormone replacement studies that I think are just really high dosages of these hormone hormones is they're looking in serum and then they're seeing the levels aren't rising. So we're increasing until we finally see the serum. What we're missing is that we've maxed out the tissue capacity and now it's slopping over into the serum and we're causing tachyphylaxis and resistance to the hormone that's being given. So your patient is applying hormones to their skin. How the heck is that hormone getting to the tissues? One theory we've alluded to is the red blood cells. So this was a study done by the Red Cross. They were looking at red blood cell membrane uptake of progesterone, corticosterone, and cortisol in fresh and stored blood. They saw that all hormones had an affinity for the red blood cells, but progesterone had the greatest affinity. Okay, so it was showing, interestingly, that female blood, because it has more progesterone, may be more stable in storage. But really, what I'm getting at here is indirectly, it's saying that the red blood cell is a really important carrier medium for these topically applied levels of progesterone. This was a study looking at estrone, estradiol, estriol, progesterone, and testosterone, finding that 15 to 35% of the total hormone content in the whole blood was confined to these red blood cells. So we have to take this into account. Remember that Vermeulen equation doesn't take this into account at all. So they're looking at just albumin and sex hormone binding globulin, but we're not, red blood cell membrane uptake is not included in that. So the red blood cells do serve as carriers for these transdermal hormones, but the bonds are weak. So when the red blood cells move through the capillaries, the hormones are easily cleaved off and moves into the cells. And I oftentimes will show my patients a picture of this, or, I have pale skin, so I can show them, my capillaries right under the surface of the forearm there. If you apply, it's really being absorbed right there, and it's going through these capillary beds directly to tissues. So they can kind of visualize and understand what's happening there. So let's return to this question, why serum is not the best testing for looking at transdermal hormones. Many reasons for that, but one of the ways is the way the serum is routinely handled. So when the blood is drawn from a patient who's been applying these transdermal hormones, if we know now a large portion of that is attached to the red blood cell membrane, to separate serum, the blood has to be allowed to clot, and then it's spun down and the red blood cells are discarded along with those transdermal hormones that were attached to the membranes. Okay, so we're just totally missing that. Another reason is just steroid hormone physiology. So these steroid hormones are lipid soluble. They're freely diffusing through the cell membrane and they're associating inside with the cytoplasmic receptors. The hormone receptor complex then enters the nucleus and attaches to the genome within that cell. The genome then activates, produces messenger RNA, goes to the cytoplasm, translated into enzymes that alters metabolism. That initial receptor hormone complex was then catabolized, broken down within the cell by the organelles. So that hormone that was entering into the cell is never seen again in that free or unconjugated form. So another reason why we just can't track that after that point. Another theory is that the lymphatic system is serving as a delivery system for the sex hormones, much like the red blood cell membrane. And this makes a lot of sense because the lymphatics track the vascular system throughout the body, and lymphatic fluid is highly nonpolar, so a perfect compatible medium for these steroid hormones. So likely that's also happening. So for all of these reasons, this is why this is the answer to when I give that table and it says no, yes, transdermal hormones are free and largely not bound to protein carriers. They have weak bonds with the red blood cells, so they're transferred quickly into the cells. The red blood cells are discarded when the serum's tested, and then we have those hormones that are broken up inside the cell. You don't ever see those again. We also have the lymphatics that are probably at play. So now we can finish this table. When we add saliva here, you can use it to look at every single medium, and it will accurately tell you, is this dose correct for, is it getting to the tissue? How much is getting to the tissue? And you can accurately and rely on that to change dosing or to alter dosing and know what you're doing. Okay. This is just an example and a picture of what the salivary hormone report would look like. So cortisol is listed there on the left-hand side, and then the sex hormones are on the right-hand side. Okay, there are some nuances to getting accurate results in saliva. It's super important that patients follow what are called the correct dosage intervals. So meaning, if they apply the transdermal hormone and then later, 5 minutes later, collect their saliva sample, that's not going to be the best way to do it, because after each saliva application or transdermal application, you do see an uptick in the saliva. We're looking for the average amount. So this is why we have these dosage intervals. So for topical, 12 to 24 hours after they last apply to when they first collect their saliva samples, and then they don't apply anymore until they're done collecting their saliva. Sublingual is a little tricky because you're using the same medium to deliver the hormone as you are to test it. So you want to make sure it's a little bit longer of a dosage interval. There's not contamination of that saliva lozenge or troche or liquid in the mouth. And then oral, they can just do that the same day on collection. So you can see there's different recommendations for each type of hormone replacement usage. For cycling women, it's important to try to test at the right time of the menstrual cycle. So, if there was a standard 28-day cycle, you're testing between day 19 and 23. But if there's irregular cycles, which is really a common reason to even test for hormones in the first place, you can follow this testing schedule and it give you an idea of how to try to time that for every, situation that might come up. Okay, putting it all back together, all mediums can be used for baseline testing, but if you're trying to track supplementation, it's really important to choose a hormone test that accurately reflects how much hormone is being taken up by the tissue and not how much is circulating in the venous blood supply or being excreted in the urine. So serum and urine are going to grossly underestimate tissue uptake of transdermal applications and often leads to overdosing and then tachyphylaxis. It may be possible to monitor oral or pellets or intramuscular with serum or urine with those caveats that I mentioned. Urine is really the go-to to understand the direction of these metabolites and therefore how are the enzymes working, how is this patient's metabolism, and I think this research is ever developing right now. Tangential but important question we typically get is it worth testing patients on oral contraceptives in saliva? I would argue no. Basically, you're suppressing ovulation, so you're going to get levels that are low, and you kind of already know that that's going to be the case, and so it's probably not super helpful clinically to just see the values unless the patient is really, wanting to see that and is really driven by the numerical data. That would be a fine reason for it. Here's an example of saliva and serum testing side by side in a patient that's using oral DHEA in a high dose, topical progesterone in an okay dose, but has a long dosage interval. And the partner is using topical testosterone. So let's explain each one of these. So the DHEA is high just because it's a high amount of DHEA to give to a woman, but you see it looks fairly normal in serum. Testosterone is high. She's getting some transference from her husband, a small amount. So this is why we see it elevated in testosterone in the saliva. You don't see that elevated in the serum because it's not high enough to slop over into the serum. Okay, but you would miss it and you wouldn't see that she's actually getting quite a bit to her tissues unless you looked in saliva. The progesterone, we found out she had been applying over fatty tissue, which causes kind of this pooling effect. So even though it looks like a decent dose topically, it's looking really high because it's kind of pooling there and just staying at that location. The estradiol is showing up high in saliva because there's some aromatization happening from the excess DHEA and testosterone that is not being picked up in the serum. So if you're trying to get these to match, especially if you're using transdermal hormones, you're going to be super frustrated and just want to call it. So know that is the reason. And this is just, a summary of the same thing that I talked about. Okay, so back to Lance. the bottom line here is that he was using olive oil dribbled under the tongue that had testosterone in it. Okay. So he was delivering this testosterone sublingually, which is very similar to transdermal, knowing that that type of supplementation would not be reflective in the serum or the urine testing that was more commonly administered to the athletes through the anti-doping control. So he was able to exploit the weaknesses in that system. He would not have gotten away with it if you were doing his test, right? Okay, so studies have been done showing that saliva testing is a better screen for doping because we can pick up these transdermal markers. Okay, so they were just showing that here. So all of the mediums are valuable. I want to say that. If we can assess the starting material through saliva and the way it's breaking down and exiting the body and giving us information about metabolism and enzyme risk factors and things like that, that would be like the perfect test, I think, is basically like a saliva and a urinary metabolite test. But we are looking at two different sides of that story, the starting point and then the ending point. So they're not going to be the same. My least favorite, as you can probably tell, is serum. However, I totally get if this is, a test that you use in clinical practice and it works for you. Just be really careful with changing dosing based on transdermals and not overdosing patients, I would say. Okay, so that's the evolution of hormone testing we've had over the years. I hope that we questioned the status quo today, but we're all still friends and we have a high amount of clinical respect for everyone, no matter what testing medium they're using, all of that. So I thank you so much for being here. I've gone over a little bit, but hopefully maybe there's a couple questions that I can answer.